couple of seconds. Away you go.
I'm Nakshatra, and I'll be presenting on the systematic review that I did, which is on setup, accuracy, and surface-guided radiotherapy for breast cancer. Before I start, I would like to thank my supervisors, Pejman, Jake, and Milad, for their constant support and guidance throughout the project.
On a screen. Yeah.
I think it's there is the logo on my screen.
I can just move it forward.
Yeah, right.
Yeah.
Yeah, that would be great. Because I'm on a different screen here. Yeah. So here is an overview of my presentation. I will be starting with the background and clinical problem, and then go into the introduction of SGRT, then the aim, methodology, results, and limitations. So breast cancer. Yeah. So breast cancer is one of the most commonly diagnosed cancers worldwide. In Australia, the lifetime risk of getting breast cancer is 1 in 7 among women. The first step in treatment is surgery, which can either be a lumpectomy or a mastectomy. In lumpectomy is basically the only part of the breast is removed, and mastectomy, the whole breast is removed. And then comes radiotherapy, where radiotherapy is used to remove residual cancer cells. In lumpectomy, the whole breast or partial breast is irradiated, and mastectomy, the chest wall, and it can include lymph nodes as well. Apart from that, it can also be used as a palliative care. So uncertainties in radiotherapy can be 2 types. It can either be geometric or dosimetric. So geometric uncertainties arise when there's a difference between the planned position and the actual patient position. And then there's dosimetric uncertainties, which can arise due to the difference in planned dose and the delivered dose. So geometric uncertainties can be due to setup errors, which is basically positioning and immobilization, organ motion, such as breathing, mechanical errors, and also contouring and imaging uncertainties. Then we have, for dosimetric ones, we've got beam modeling and calibration, dose calculation, anatomical changes, and geometric errors, which can propagate into dosimetric error as well. The main focus of this presentation will be the setup error, which happens when the treatment position and the planned position changes. In conventional practice, the main methods to tackle this problem is IGRT and tattoo-based alignment, and we'll get into that shortly. So first, there's IGRT.
I have to pause for a second. The slides are not changing online, so just stop sharing for a moment, I think.
So I can work on it. So it's working now. You just need to click on it. That's fine. So it's now.
It's not working.
That's right.
Either, though.
Just
Right,
should I?
guys, please, yep, keep going.
Yeah, so IGRT uses X-rays or uses the imaging to visualize the anatomy of the patient and to target the tumor cells, basically for localization. we've got over the past 3 decades, they have evolved from 2D to recently 4D CT and 4D CT, which incorporates time into it as well. And in the current practice, CBCT is the gold standard. So limitations of IGRT can be, the first limitation is repeated imaging dose, because repeated imaging adds extra radiation and it can be cumulative, which is of a big concern. Then there's increased time. So imaging acquisition, reconstruction, and registration takes a lot of time, and this can make the patient, it can increase the risk of intrafractional motion and also patient comfort. And then there are no continuous monitoring. So these are basically snapshots which are on, these are basically active snapshots. So there's no continuous monitoring happening there. And then post soft tissue visualization in case of KV or MV. And the alignment is on bony anatomy, so it's not the actual target. So especially for breast cancer, it's a soft tissue, so anatomy, just on bony anatomy cannot be that accurate. Traditionally, patient positioning for breast cancer radiotherapy has been using tattoos. These act as fixed points that room lasers are. These act as fixed points that room lasers are aligned to, and then the patient is set up based on that. So that is an example of the skin tattoo. It's just a small dot. And then in the bottom picture, usually the number of tattoos varies a lot between different institutions, but usually it's 3 to 4 tattoos, and also based on what type of breast cancer it is. That's the alignment of the tattoo using lasers. Now, these tattoos, while they are helpful, they've also got a lot of limitations. They have cosmetic or psychological limitations, as they're a constant reminder of the cancer journey of the patient, which is quite challenging. Some cultures don't allow tattoos. That is also a concern for some patients. Then tattoos can be harder to visualize on darker skin tones, and there are risks of misidentification, as well as they can resemble other marks or moles. Skin stretching or weight changes can reduce accuracy, especially in breast cancer. And permanent tattoos are done with needle and ink, which can cause pain, irritation, allergic reactions, or infections. Temporary tattoos have been proposed to alleviate some of these concerns, but again, in the end, these are just 3 to 4 points, making them insufficient for precise precision. And this calls for advanced setup systems like SGRT. The Surface-Guided Radiotherapy, or SGRT, is a non-invasive technique which uses 3D optical surface imaging to track the patient's position. The system captures a live surface map of the patient and then compares it to a reference surface. Then compares it to a live reference surface acquired. The reference surface can be generated from the CT in the DICOM form or in-room cameras. And it provides real-time feedback in 6 degrees of freedom. So basically, the entire region of interest is considered, and not just the tattoos. Those are the cameras in the treatment room, and the bottom picture represents the surface created from the CT. The pink mesh is the surface, and the gray area is the region of interest. Now, deep inspiration breath hold is a technique where the patient is asked to take a deep breath and hold it physically, which physically moves the heart away, and it also stretches out the lung tissues. thereby reducing dose to these organs. Now, surface-guided radiotherapy allows us to monitor the patient's surface in real time, and this ensures they are holding the breath at the right time. And we can also set preset thresholds. And when they drift out of these preset thresholds, the beam falls, adding another layer to safety. So SGRT provides multiple clinical and patient-centered benefits. One major benefit is that it doesn't rely on tattoos skin marks. It is non-invasive and doesn't use ionization. The system also offers real-time postural tracking with its giving a more objective field of view, objective data set and a large field of view, and also reduced those organs at risk with those two organs at risk with DIPH. Importantly, it also reduces setup time and minimizes the need for additional imaging because of its accuracy and beam gauging as well. These are the current commercial SGRT systems. The cameras are given on the top. They are AlignRT, Catalyst, Identify, and Exact Track. The bottom picture, the B represents AlignRT in the treatment room. AlignRT, Catalyst, and Identify, all three of them use 3 camera units like the first picture. Exact Track uses just 1 camera unit, but it combines X-rays, a newer technology. It combines X-ray tracking, thermal, and surface tracking. So it's IGRT plus SGRT in one system. To give better clarity in this picture, on the left side, the green area is the reference surface, and the purple part is the live reference, live surface of the patient, which is a bit deviated. And this color map can be projected onto the patient as well. On the right side, it is a still after positioning, so the errors are corrected. And then this is a feature in AlignRT called postural video, which basically the reference gives its reference is an outline, and the patient can be adjusted based on it. And it will also give the deviations on the system. The white lines indicate the thresholds, and when it goes out of the threshold, which is it becomes red and the beam pauses during a live treatment. Now, coming to the systematic review, the aims of this review was to evaluate the accuracy of SGRT compared to tattoo-based setups, considering both translational and rotational errors, and to assess the efficiency using setup times between SGRT and tattoo-based methods. And the third was to identify limitations reported in various articles, including technological, clinical, and practical challenges. The methods, so it started with a database search using the databases PubMed, Scopus, Web of Science, and Google Scholar. For this review, I included studies that focused on breast cancer and also using photon beams, and excluded all electron, proton, and other beams. So that is a Prisma flow diagram. The search yielded 227 articles, and after adding a lot of filtrations, the included studies, I included 16 studies. So the data extraction included the author and the year, patient characteristics, technical characteristics such as SGRT system, and the LINAC model, comparator, which is the tattoo, setup accuracies in different metrics, verification method, workflow, and also the reported limitations. And these were quantitatively analyzed by looking at different error metrics, and visualized using box plots and analyzed with a significance test. Qualitatively, I summarized workflow observations and implementation challenges with a focus on setup accuracy and operational efficiency. So this table gives a summary of all the studies. The studies were arranged by date, with the most recent ones on the top. I recorded the number of patients, the treatment site, which varied a lot. SGRT systems, most of them used Align RT, while 4 studies used Catalyst. Techniques, dose prescribed, as you can see, they are hypofractionated, so this enhances the need for precise positioning. IGRT modalities also vary a lot. CBCT and orthogonal KB were the commonly used ones. So SGRT tolerance, it is the tolerance out of which the beam holds. 3 millimeters and 3 degrees were used in most of the studies because they are recommended by the vendors. And then whether DIBH was used or not. So the results looked at the mean translational error, including the standard deviation and 3D vector error, the mean rotational errors, and some studies reported it as random and systematic errors. So I've included that too, and then time limitations. This is a table that summarizes all the translational error data, which has been used to create a box plot for comparison. As you can see, the x-axis shows the translational axis, and the y-axis represents the errors in millimeters. The blue boxes represent SGRT, while the striped ones represent tattoos. And over here, SGRTs yielded less setup errors compared to the tattoo-based ones. The red dots are the means. And in general, SGRT performed better. But the significance test showed no difference. The errors were highest in the vertical direction for both methods, mainly due to respiration. And additionally, a few studies reported that the patients tend to lower the thorax after, in between the positioning and IGRT because of relaxation. And this was confirmed after looking at the SGRT real-time data, the logs from the system. And then we've got mean rotational errors. Mean rotational errors were small for both SGRT and tattoo-based alignment with minimal differences, indicating that translational shifts are a major component of the setup error. Now, SGRT showed slightly narrower standard deviation, suggesting consistency, and however, detection is limited by KV and MV imaging, and couches often lack full 6 degrees of freedom, so SGRT can help with that. Again, from the limited data available, SGRT showed better performance in the rotational axis as well. Then another 5 studies reported random and systematic errors. For better visualization, I've created a heat map. On the right side, the tattoo-based setups across the 3 axes are given, and on the left side, split like this, and on the left side, there's SGRT along the 3 translational axes. The darker shades of blue indicate higher deviation. So you can see that SGRT consistently showed errors that are less than 3 millimeter in both random and systematic errors. I also combined the errors using RMS method, to make the difference a bit more clearer. So the tattoo side consistently showed higher errors than SGRT. The vertical axis shows a statistically significant improvement. Clinical implications from the observation. So 4 translational errors SGRT can potentially replace tattoos without compromising accuracy, though daily IGRT is still recommended. It supports more accurate posture control, reducing residual errors and 3D vector errors as well. The visual feedback, features like visual feedback, postural video, and color map projections can further enhance the accuracy. SGRT also provides objective 6 degrees of freedom, 6 degrees of freedom information, helping to reduce the inter-therapist variability and can visualize anatomical changes such as swellings or weight gain or loss, enabling an alert for the RTs or the medical physicists to replan. For rotational errors, feedback-based repositioning is needed. Based repositioning is required if the couch does not support 6 degrees of freedom, and also the rotational errors are less significant than translational errors, but still impactful when it comes to small tumor sizes. Most residual rotational errors can be managed with minor repositioning guided by SGRT. The next metric assessed was setup time. On the x-axis are the different studies, and the y-axis are the setup time in minutes. The green bars represent tattoo-based setups, while the orange and the yellow ones represent SGRT systems, Align RT and Catalyst. Overall, SGRT setups were faster, though the difference were kind of small. It's on an average a difference of 2 minutes, with SGRT being 6.2 minutes and tattoo being 8.2 minutes. However, when considering the total time treatment, SGRT is efficient because it reduces imaging time, and also the time to place the tattoos can be skipped. Since SGRT, it has a lot of benefits, but it possesses some limitations as well. SGRT relies on external surface, so it doesn't always correlate with the internal anatomy, and that's why periodic IGRT is still important. It also changes like weight loss, edema, and breast shape can affect the accuracy of the surface. And in cases of pulse placement, it can interfere with the image quality because SGRT depends on reflections from the patient surface, and most conventional pulses are kind of reflective and a different color from the skin tone. Technical factors like camera occlusion from the gantry and the couch movements can happen. Also from the abdomen in high BMI patients can cause occlusions. Different skin tones require calibration and proper optimization of the camera settings. From a workflow perspective, SGRT systems are quite expensive. A survey conducted in 2020 the results show that the cost was the most impactful hurdle against implementation of SGRT. They also require staff training and time to adapt. The workflow integration, which can be quite challenging, especially in busy clinics. And then the limitations of the study. The studies included in this review used a range of treatments such as whole breast radiation therapy, accelerated partial breast irradiation, and RNI. And they also differed in the IGRT modalities used. The variation in cohort size, patient type, error reporting, all these added to the heterogeneity of the study, and therefore a meta-analysis wasn't feasible. And then some studies used hybrid workflows combining SGRT with tattoo-based alignment. there were also differences in the reference surface used and also the adaptation, basically the workflow, because until 2022, there weren't any guidelines on SGRT and it was just on a trial basis. The system differences is another point. Studies use different SGRTs like Vision Art by different vendors like Vision RT and CNAT, which have unique features. This can also potentially cause some discrepancies. Another, finally, the most of the data were based on reported means and not the raw data. And this limits the precision in inter-study comparisons. Clinical applications and future directions. Now, SGRT has several expanding clinical applications. It's now routinely used with DIVH, helping improve reproducibility and also intra-fraction monitoring with beam gating. Looking ahead, SGRT has potential applications beyond positioning. It could be used for biometric identification to verify the patient. And a lot of vendors have been trying to integrate this into the SGRT system. So SGRT is also expected to play a critical role in adaptive radiotherapy and automation of the couch, where the real-time surface feedback can be used to create a more closed-loop closed-loop radiotherapy system, where SGRT can be integrated with AI to build more of a predictive approach to the positioning, and automatic couch movements as well. Now, further research comparing SGRT with IGRT could help in minimizing the imaging dose and improving the workflow efficiency. Finally, to strengthen evidence and consistency, standardization is also recommended. So to conclude, SGRT demonstrates superior setup accuracy and consistency compared to tattoos. Though daily IGRT remains important, with its advanced features like real-time positioning, real-time monitoring, gating, and adaptive features, SGRT could potentially play a crucial role in radiotherapy. And that's it. Thank you.
Thank you. Well done. I'll jump in with a couple of quick questions.
Yeah.
So you mentioned at the end standardization was needed and multi-institutional studies. Just wondering what you meant by standardization. What do you think has to be standardized?
Some, like I mentioned, some of the reports use a dicom reference and some use in-room cameras, and even so there are a lot of differences in the workflows over there. So a good guideline could help in comparing and standardizing the work.
Okay. I also was just wondering, in any of the studies that you looked at, were there any randomized studies that differences, I mean, not even necessarily for accuracy, but maybe even for just patient outcomes between the two modalities?
All of the studies suggested that SGRT is better, but okay, these studies were done, some were randomized studies, and also most of the studies I think used an alternative method where in one fraction they used SGRT and in another fraction they used tattoo-based alignment to compare. And also it kind of reduces the inter-patient variability as well. But yeah, sorry, what was yours?
I was wondering if there's any randomized studies, and do you think they're potentially more important to consider than the non-randomized studies.
Randomized. Yeah, I mean, it can cause discrepancies if it's not randomized, but most of them were in a random basis.
Cool, thank you. Any other questions?
Nakshatra, when I was a little bit confused, so when you talk about the tattoo alignment, that actually means tattoos and imaging, doesn't it?
Just tattoo. So SGRT, I'm proposing SGRT as a replacement for tattoo-based alignment and not imaging.
So when
So
tattoo alignment's done, isn't there an image?
yeah, it is followed with an IGRT.
Yeah.
And in this method, in SGRT, so the initial positioning is done with SGRT, and then there's verification with IGRT as well.
Oh, there still is.
Yeah, there still is, but then, yeah.
I was a bit surprised how close how small the difference was.
Yeah,
So,
yeah, it's still, IGRT is still recommended, and it
Yeah.
is still gold
Right.
standard. It's just to avoid the tattoos
Sure.
and
So-
the other benefits.
Has there been has any other studies compared to dosimetry that have been the impact of this relatively small difference?
Most of the studies, since it was initially proposed as a positioning technique, a lot of them just focused on the positioning.
Okay.
But I think 3 studies looked into DIPH dosimetry as well with SGRT, and they showed that it is better with the dosimetric results showed that it is better with SGRT than other DIPH methods like RPM. So yeah, that was also positive.
Good. Any other questions? Okay, well, good, thank you. Stop recording, and yes, now we can all have a quick lunch break. We're a little bit over time, but we'll be reconvening here in about 40 minutes at 1 o'clock to do the final 2 presentations. Thanks, everyone.